how to initiate a basal insulin. So coming to the basal insulin is very important. The first insulin you should initiate is basal insulin because it is easier to initiate. Not that you cannot give a premix insulin initially, but basal is much easier to start with. So all the guidelines will tell you start with 10 units at the bedtime, 2 units every day you titrate, or maybe you can titrate slowly. Sometimes we tell them to titrate 2 units every week also. Sometimes the patient is good motivator, you can do fasting blood sugar daily. You can tell them to monitor, give every day 1 unit, you can titrate up and give a target to the patient. Again, that is another point, that my target you should reach at 70 to 130 or 90 to 130 or 100 to 130. So this some target you have to give it to the patient so that you titrate to that target, treat to reach the target. That is the goal, that is the motto. So you have to go to some target, so you keep titrating till you reach the target. Once you reach the target, you stop titrating. So look at a case scenario where you have a basal initiation, where you will initiate. This is Mr. JS, who just come with a history of type 2 diabetes, with long history of 8 years type 2 diabetes, on glimepiride metformin combination of 2 milligram and 1 gram, and sitagliptin 100 milligram. So already he has a 3 full drugs he's taking, 3 oral agents and full dose. I think more than 4 milligrams of glimepiride, you're not going to get benefit by increasing it to 6 milligram or so. BMI is 30, his weight is 80 kilograms, hypertension, ischemic heart disease. There's a mild non-proliferative diabetic retinopathy on the eye examination. Look at the fasting blood sugar is 230, postprandial is 295, A1C is very high, 9.5%, and creatinine is 0.9. So you can clearly see that the fasting is very high, postprandial is very near to the fasting blood sugar. So when you see such kind of scenarios where postprandial is not very high and fasting is more contributing, more like 230 295, difference is only 65, hardly any difference between the fasting and pp. That means fasting hyperglycemia is contributing more to this dysglycemia. Hence, if you control the fasting, you probably will take care of the postprandial also. So it's called what we say, concordant blood sugars. They are matching each other. If you cut down one, automatically the other will go down. So this is the scenario here, this is the situation here. So we started the insulin 10 units by the dose 0.2 units per kg body weight. So you can start with 16 units also. You can start with 16 units, but if somebody is not confident, it can start from 10 units. Guidelines say 10 units because people are not confident of giving 0.2 units per kg body weight directly. So you can start with 12 units, or you can start with 0.2 units per kg body weight. Then in this case, it becomes 16, and then you start doing fasting sugars every third day at least, or minimum once a week. So you can titrate every third day. After 3 days, there's the fasting blood sugar, and it is coming to normal. He can stop titrating. Or sometimes people are not willing to monitor, so start slowly, give 8 or 10 units in the night, and then wait. And then after 1 week, tell them to do the blood sugar. If they can do blood sugar fasting at least once a week also, then you can slowly up titrate maybe 1 or 2 points every week. And this is how you should target. And after giving the target, you should stop titrating once they reach the target. So titrate 2 units every 3 days, or 2 units once a week, as per the monitoring. If the patient is ready to monitor frequently, you can do it every third day, or you can do it every week. This is how you should do it. Once you have an oral agents, and a patient is newly diagnosed, A1C is 9%, patient is symptomatic, losing weight, you can start with basal insulin first and give one oral agent or 2 oral agents, and then if required, you can intensify. And sometimes we slowly remove the basal insulin and continue with oral agents only. Or if the patient needs, then you can start with you can add a prandial insulin, intensify, you can add a GLP-1 receptor agonist, or you can switch to premix insulin if you require more shots. So you can switch to 2 shots of premix insulin to give that same control with a lesser shots. If your oral agents are failing in most patients, which are the scenarios nowadays, you can start with basal insulin, then you can go to basal plus, means one prandial shot, one meal which is very heavy, that you can address with a short acting insulin or rapid acting insulin, and one basal insulin to address the fasting sugar insulin. Or sometimes patient is not willing for 2 shots, then you can give one premix, so that it can address 2 components. One is a prandial component, one is a fasting component, and slowly up titrate to 2 or 3 shots of premix insulin. Or some people are motivated, then you can use a basal bolus. Basal bolus is the best because you can control all the meals with the short acting insulin, and as well as you can control the fasting sugar with the long acting insulin. But the patient is not willing, then you can go for a 2 shots of a premix insulin. That also will be sufficient to take care of. But of course, hypoglycemia risk is slightly increased if you use a premix insulin. That always remains. So this patient comes with a now loss of vision. You started the basal insulin, we know that, and you titrated the patient's insulin also. And this now has come after 9 months. You have given the insulin, is okay, but he has started having the vision problems now, because I told you he has got non-proliferative diabetic retinopathy. So of course his vision is deteriorating now. A1C is 8% from 9.5%, which was earlier, and other labs are normal. Now he's taking 20 units of glargine insulin basal. So he started with 10 units, now he's come to 20 units. His fasting sugar, you can see it has come to normal. You can see we have reduced the dose of glimepiride. Whenever we start a basal insulin and we have a sulfonylurea, you will have to reduce the sulfonylurea dose to at least half. In this case, I have reduced the nighttime insulin of sulfonylurea to the half. Sitagliptin is same, and so DPP-4 inhibitors have to be kept same. So when you are giving insulin to the patient, you have to titrate. You have to look at the other drugs also, oral agents. Sulfonylurea specifically, you have to cut down the dose to 50% sometimes. So start with the insulin. Once the sugars are getting controlled, start reducing the dose of sulfonylurea. That's what you should be doing. So in this case, the fasting sugar is controlled, but you can see the postprandial sugars, post lunch is high, post dinner is high. So now this is the most important sugar here. Post dinner is going very high, and the patient's dinner is heavy probably. So now we have to address this, because this vision is going down. We have to bring this 8% to 7%. So either we stop glargine and give a premix, that is also a good option, or I will continue the glargine insulin, this 20 units, and add a prandial shots in the dinner, or I can add a oral agents. Anything is possibility here. But because the patient has got vision symptoms, I need to bring down this blood sugar quickly. And as I said, if you have a complication, insulin works the best. Microvascular complications like retinopathy, we have to use a insulin. So that's the reason I will choose a prandial insulin before a dinner, and that will take care of the post dinner sugar. So if you give a shot before the dinner, post dinner sugars will automatically get controlled. Your fasting is already controlled, so you will be able to give a good reasonable blood sugar control to this patient with 2 shots. So what is the difference between the basal pre plus and premix? So I can use a premix or I can use a basal plus. So which should I choose? So the difference is that there will be one extra shot, but there will small risk of hypoglycemia. How? Because if you are choosing a 30/70 insulin at night, so you can use, when you're choosing a 30/70, if you're using any units, 30% of will be short, becomes a short acting, and 70% will become a long acting. Remember that. So if your 30% is going to match the dinner, then it's fine. But if your 30% is not going to match the dinner, the post dinner sugar will not get controlled. Now if you're trying to control that post dinner sugar and increasing the insulin before dinner, probably that can happen that you can give a hypoglycemia, fasting hypoglycemia to the patient, because you are trying to increase the dose of the premix in the night, and your long acting component is also going to increase. So remember this, that because of this reduced flexibility, the risk of hypoglycemia is more as compared to basal plus. And but premix becomes convenient because one pen, with one shot you are able to adjust. So if your patient's sugars, you know that your insulin dosage is this much, and if your fixed doses are fixed, there's not much change in lifestyle, premix is the best. Then the dinner doesn't change much, the carbohydrate content is almost the same each day. Premix insulin will be the best suited for the such patients. But when the lifestyle is not very set and things keep changing, dinner times keep changing, premix will not be a good idea for such patients. So this patient who comes to me now after 7 months, he had a vision problem. We know that we started with basal, then we added extra shot in the dinner. His A1C has come to 7.6. His basal insulin is fixed at 20 units. His hair is taking blue lysine insulin at 6 times at dinner time. His sugar seems to be in a reasonable control, but again the post lunch is going high. Probably his carbohydrate content is very high. Now I will try to counsel this patient that you need to reduce the carbohydrate content, but I need to control the blood sugar, so I will add another shot at the post lunch, pre-lunch, so that my post lunch blood sugar should come down. So this is the another one option. Or now I have to, because I am adding a third shot, patient may not agree, and this patients, then we can change it to 2 shots of premix, one which will take care of the post lunch. So you one shot you can give in the pre-dinner, and one shot you can give in the pre-lunch. Now remember, analog insulin you can give like this, or co-formulation is the best, which you can give at lunch also and dinner also. But if you are using an analog insulin, or sorry, the human premixes, then you should have a difference of 12 hours before the next shot. So you have to use first in the fasting and second shot in the dinner. You can't use a one regular premix insulin, one in the lunch and one in dinner time. There will be risk of hyperglycemia is more because of the long acting component. So you have to use co-formulation insulin here if you want to control the post lunch and post dinner components both along with long acting. So this is how you can change it to premix. But generally prandial sugars, you have to use these, you have to control, so you can give extra shot, you will be able to control better. So you have a 20 units of glargine, one shot of glulysin pre-dinner, one shot of glulysin pre-lunch, and this is the way you can control. You can see the blood sugar, the post-lunch blood sugars are very high here. Post breakfast are high, but we can counsel this patient to reduce the carbohydrates. Probably with the you can be able to reduce the post breakfast sugars, but post lunch dinner sugars needs to be addressed by a extra shot of insulin. So this is how you are intensifying. So from one basal you went to one from basal you went to bolus and second bolus, and this is the way you can adjust the insulin depending on the blood sugars. You can adjust titrate as per this chart. You can see if the blood sugars your target should around 120 to 100 to 120, but if they go it's pre-meal insulin its sugars are going very high, you can add 1 point for each increase in 20 milligram per deciliter. For some people who are insulin sensitive, you can add 1 point for 40 increase in blood sugar. So suppose your target before the meal is 120 and now the patient is at 200 before the meal. You have to adjust 2 units, give 2 units extra to adjust this 200 to 120. That is 80. This is patient is 80 more than your target. Then you have to give 2 units or 3 units extra, and that will bring down the patient's target. That will bring the patient back to the target. So this is called correction insulin. So this is how you are going to adjust this patient's corrections also.